To help us make care safer through parties and teams and organizations that are all doing the same. The purpose of today's webinar is to celebrate the winners and inspire others to follow in their path. We want each participant to take at least one practical idea for home organizations to implement, even if it's as simple as sharing a story or learning that they've learned today at the webinar. The purpose today is quite simple. We're going to hear from the winners, Jimbo on the patient award and Michael Guerin Hospital on the team and organization award. Then we'll have a short Q&A followed by two other presentations, the honorable mentions from the patient and the honorable mention from the team and organization. Entered in the registration form we captured, and we have them here on this slide. Kathleen, our moderator for today, will use those to make the conversation. However, if you have learning objectives or questions, or you want to participate in the conversation, please use the chat box. Tell us your questions. We are going to pay attention to the chat box. To practice that, why don't we begin by each other where you're from, just your city and your province. Now, trying to find the chat box and tell us where you're from. You know that this session is recorded because we want to share it with those who couldn't be here today. So that's the purpose of recording it. However, the recording will not include the chat conversation, so don't worry about typos and spellings. That's just for us. Give our partner organizations a moment to recognize you here. So I'm going to turn it over to Jessica Gisberg, Director for Quality, Performance, and Evaluation at Healthcare Kahn. Jessica, over to you for some opening comments.
Thank you, Anna. I'm so pleased to be here with all of you, and thanks to everybody from all over Canada for attending today. We've had the privilege of partnering with CPSI on the Champions Awards for 2 years now, and rolling into year 3, which is really exciting, and continuing to improve and develop those awards as we work together. And we're very proud to partner with CPSI on a number of initiatives, other education programs that we partner on as well. So thank you to you and all of your team, Joanna. And thank you to all of those people who submitted nominations. I had the privilege of reviewing all of those as well with the team, and they are all so wonderful. And so for Healthcare Kahn, it is just so important to be able to honor and also share the innovations that are happening in organizations and with patients and families to partner together to further patient and family-centered care and patient engagement, and thereby improving patient safety. And it's certainly one of our priorities as well. So we look forward to hearing from you today, and thanks again, Joanna, for leading us today.
And Steffi, Senior Director from the Canadian Patient Safety Institute, will join us at the end, and she will have the pleasure to announce the 2017 Champion Awards. And let me tell you that how pleased I am to see how the participants come from all over Canada, from sea to sea to sea, including Whitehorse. So welcome to all of you. Keep telling us in the chat box where you come from. I would like to take a moment and thank the judging panel for the exceptional work they've done this year judging the nominations. We received wonderful exemplars of work from across Canada, and it was very, very impressive. Those 6 judges did not have an easy job. So Ed Cry, Kathy Litwin, and Anna Price were representatives on the judging panel. Candy Sina, Sonia Green-Hush, and Amir Karmali were team organizational representatives. Ed and Candy have been past judges on the Champion Awards. Johan and Amir have been past winners. Kathy represented Patients for Patient Safety Canada, and Sonia represented Horizon Health, the organization that hosted the awards ceremony this year at their very beautiful conference in Moncton, New Brunswick. So with my host job is almost done. I just need to introduce you to our wonderful moderator today. Kathy Litwin is a member of I would like those speaking to just mute their lines. Done. So Kathy is a member of Patients for Patient Safety Canada. She came to us as a volunteer over almost 5 years ago because of a personal experience with preventable harm with a family member. Since she joined Patients for Patient Safety Canada, she has been active with the Knowledge Transfer Working Group and partnered with the Canadian Patient Safety Institute and others across the country in patient safety initiatives. Kathy, as most of our members, is World Health Organization patient champion. Kathy is also passionate about patient safety because of her work experience. She's a patient specialist in the Patient Safety and Experience team at the Health Sciences. We've been involved in multiple initiatives, beginning with Canadian Patient Safety Week, which was a big success this year, falls prevention, and so much more. It's an honor to have you here, Kathy, to take us through the next portion of our program.
Thank you, Ioana. Welcome, everybody. Canada is home to many innovative, remarkable, and passionate individuals who are committed to improving the quality and the safety of care for our patients and communities, and thank you for that. I'm very honored to have judged awards this year, and I'm very honored to be able to moderate today's event. We're really surrounded by extraordinary people who continue to strive to improve their innovative thinking, partnerships, and teamwork. And work is extremely humbling, and it's inspiring as well. You're a huge inspiration to all of us. Look forward to hearing more today on learning from each one of you. The Volunteer Champion Award recognizes a patient and family volunteer who, through exemplary dedication and service, contributed to a project or initiative that resulted in identifiable improvement in patient safety outcomes. Pleasure of introducing Trimble is a patient partner with the Community Engagement Advisory Network in BC and was nominated by Belinda Boyd from Vancouver Coastal Health Authority. She's a patient partner, especially when it comes to elderly over-medication. Since 2010, she has been a member of local provincial and national patient groups. She's been an inspiration and motivator for other patient and family volunteers, and she is the first winner of the Patient Award. Joanna, welcome. Congratulations.
Thanks, Kathy. I can hear me, everybody. I just want to tell you what a wonderful pleasure it was the award at Pharand Health on patient experience. The whole 2 days was to Pharand's wonderful efforts to include in every decision at every level. Particular pleasure for me because I received it in New Brunswick, and my grandfather is from an old Harvey, New Brunswick family, and I had never been to New Brunswick before. So it was beautiful, and I felt that all the people there were probably cousins in one way or another. It was, I really want to thank them for showing me such a wonderful time and Sir Liam Donaldson is the patient safety envoy from the organization, was there and opened the conference with a wonderful keynote. Next, please. So I just want to about work that I've been doing here, a lot of it in BC, but some of it national as well. Probably the one for me that's most prominent because it's the closest to my heart is the BC Polypharmacy Risk Reduction Initiative. And this is an initiative that's funded through the Ministry of Health and Doctors of BC, which is the medical association here. And we're working with residential care facilities all over the province doing training and motivation and mentoring to help the doctors and medical directors doing really meaningful medication reviews for people in residential care. Quite often it's just a matter of rubber stamping a list that the person's already on. It is a mandated activity. You have to do these medication reviews. So we're trying to do training to make sure they're done as meaty as possible, and really an eye to, are there too many drugs? Are doses too high? Are they on drugs that they no longer need or that are causing problems with their quality of life and really being very beneficial? So I've been this for about 4 years, and it's really, I think, what really motivates me so much and why I love this project is because we're making actual meaningful change at the bedside. I admit that I know health policy is important, but going to a lot of meetings about health policy just does not turn my crank, where this kind of work really does. Next slide, please. Along the same lines, I'm the public member of the faculty for the Call for Less Antipsychotics in Residential Care. This is another provincial initiative by the BC Patient Safety and Quality Council. We're with residential care facilities all around the province, looking and training on how to reduce the use of antipsychotics and use different ways, non-pharmacological ways of working with people who are having behavioral problems that are disturbing either to themselves or others. So a real eye-opener for me also to see the dedication, a lot of the people that work in residential care and how much they want to provide care for the people that they care for in their homes. One of the things that I try and do always in both these projects is to ask to really make sure that the family is involved and included in the elder, and letting professionals know that they have a lot of good information and they will notice that not be used by professionals because they know that person so well and they know their baseline. So that's a really important thing for me to try and get across. Next slide, please. So one of the been really delightful for me to try and get this idea across is for about 4 years now, I've been participating in the Community Geriatrics lectures to the first year medical students at UBC. It's due to Dr. Margaret McGregor, who I've gotten to know very well, who runs that program for the Department of Family Practice. And what I there again is talking to the students about the kinds of knowledge they have about the frail elder, and they can include the family in use them as their eyes and ears, because they're ones that are beside the side for hours at a time and are noticing changes. So I'm working also with Fraser Health Authority to do some work around polypharmacy. And one of the things that myself and a colleague did is we went out and we family councils of the residential care homes in Fraser Health about the polypharmacy work. Administration was worried that people might think that the administration is trying to cut down on drug costs by removing drugs, but in fact we found the opposite. Families were very, very interested in having less drugs and having their loved ones with a better quality of life. Yes, there's the students all listening with rapt attention as I lecture to them. Actually, that's not true at all. This is true I found online. But we did, in fact, have a really good response from the students. Next slide. I'm very, very interested in, because I come from a library background and I'm a bit of a data geek, actually. I like looking things up. I know how to do it. A lot of research when my mother-in-law was having drug interaction problems. This is a Canadian site that I really urge you to go to, and I've been involved with helping make it more consumer-friendly. And there will be additional tools available in the spring. Right now there are interaction checkers where you can put the drugs in and it will show you if there's an interaction. It's a public website. It's quite easy to use. And it'll pleasure to work on this and understand that it's that musically they don't have to have a library background as I did several years ago in order to find information. It's just a lot more accessible, so I'm really happy about this. Please. Next slide. Whoop, one. This is another online tool. You can actually go to it now, medstopper.com. It was developed for physicians, but there will be a consumer version that's just starting to be worked on now. And it is a way of putting in a list of medications that an elder might be on, and it will rank them in order of which ones are considered first for either upping or reducing. In other words, the ones at the top of the list, once you've added all the drugs, will be that are the least efficacious or the least safe. So you can that list, and you can take it to your family doctor and have a conversation about having a really meaningful medication review to make sure they're not on drugs that you shouldn't be on or the dose might be too high. Some drugs are started by many different prescribers, and really somebody needs to be in charge of reviewing that list. It's very important. It's been a real pleasure for me to be involved in the development team. Online tool. Slide, please. Things that I have found is that when you find physicians that are really on the same page as a patient representative, don't try to suggest that might present with them. So this is a presentation, a workshop actually, that I did with Dr. Kahn from Sweden and Dr. D. Mangan, who's from McGill University. All three of us very, very interested in over-medication problems, able to write an abstract and ended up presenting at the Preventing Overdiagnosis Conference at Oxford 2014. What a thrill that was. I still have a chestnut from one of the Oxford chestnut trees on my counter. Next slide, please. And thing that for me was surprising and wonderful is I reached a provincial appointment, member of the BC Patient Safety and Quality Council. The thing I find so wonderful about this, not only are they great people to work with, but I was the first, I think, patient, I was a person from the patient world appointed to the council. Mostly it's community leaders, healthcare leaders, and so, I think that's the end. I set my timer so I wouldn't go over time, and that was 10 minutes. Yes, this slide, Dr. Liam Donaldson who spoke at the conference. Yeah, how do you remain outsiders when you work within? The way we do that is we never forget why we're doing this work. Next page, or next, please. To love, have suffered harms, and to make this a meaningful situation for ourselves, and to make sure this doesn't happen to anyone else. Slide, please. To do this work, next slide, please. And I did to my mother-in-law, who started all this work for me years ago. Thank you very much for your attention. I welcome any questions.
We're moving to questions after Mary is speaking, correct?
That's right.
Okay, thank you. Hannah, thank you very much. That's very touching, and you've been a very busy woman, and we thank you for that. We'll move to questions after our next award. I have the pleasure of presenting the Team Organizational Champion Award, rising a team or organization who, through exemplary patient-centered care and patient engagement practices, contributed to a project or initiative that resulted in identifiable impact on patient safety outcomes. And the winner of the Team Organizational Champion Award is the Michael Garron Hospital, formerly known as the Toronto East General Hospital. They were nominated by Francisco Grales from the Canadian Envoy at the Radboud University Medical Center. Representing Michael Guerin is Mary Iramoto, Director Quality, Operational Excellence, Privacy and Innovation, who talking about their outstanding work in partnering with patients and families in continuous quality improvement and in shaping a culture of engagement across organizations. Welcome, Mary.
Great, thank you very much. Can I take over the slides? Perfect. All right, so thank you, Kathy. We're very honored and extremely excited to have received this award on how we partner with patients for quality and safety. A great thank you to CPSI and Healthcare Kahn for the opportunity to share our work. And of course, we want to thank Cisco for our nomination. So, short time frame that we've been provided, I would like to give you an overview of how we include patients in safety, but I also appreciate that we will only skim the surface on a number of these initiatives and strategies. So I've included my email address at the end for participants who are interested in learning more information. So first, let me provide you with a little context as to who we are. We are a large community teaching hospital located in the east end of Toronto, Ontario. You can read on the slide, we have over 2,400 staff, over 400 physicians and midwives, a very dedicated group of 500 volunteers. We have a highly diverse low-income community. Our patients speak over 50 different languages, which can all present additional challenges in communication and care. We have over 75,000 emergency visits each year, and it continues to rise. We're a hospital with a strong continuous improvement or lean mindset. And one thing that can't be illustrated on this slide is our strong and long-standing bond and relationship that we have with our community. So, our philosophy of partnering with patients is grounded in our MGH patient-centered care framework that outlines the ways patients and families should be involved in healthcare, decision-making, and design. Partnerships range from participating directly in their own care to providing input into new initiatives to co-designing through various committees. Patient choice is at the center of these relationships, and they choose the extent to which they engage. Examples on the slide here provide the span from bedside to boardroom in terms of where they want to partner and where they want to engage. Now, there are a number of initiatives that this presentation will highlight, but to take away one key message from this, and that is that each example is just one part of a larger patient and family engagement strategy that's much more than a collection of initiatives or projects. Partnering with patients at all levels of the organization, it's become the cultural norm of our hospital, and it's becoming now simply a way of being and doing for us. We've also been trying to make a distinction between a task versus a culture, which is why we've been able to sustain and increase including patients as true partners. I believe strongly that patients are the experts in their own experience, and we've been formally including them since 1996, when patients first were appointed as members of our Research and Ethics Board. We have continued on a journey to actively partner with patients since then. A key component of this journey is patient engagement in making the patient voice a consistent part of daily activities. The word "nothing about me without me" define the core of our belief. And we answer this around a diverse set of channels highlighted here that enable us to both collaborate with and seek input from our patients and families in a structured way. Some channels include leadership rounding, patient satisfaction surveys, post-discharge phone calls, and social media. An example that I'd like to highlight is our patient video program, which was developed as a tool to give patients a voice and to provide a first-hand account of their hospital experience and opportunities to change. It provides staff the opportunity to better understand and reflect upon their care provision from a patient's perspective. Since 2011, almost 150 patient videos have been recorded and shared. These are 3 to 5 minute videos where we ask patients 3 basic questions: what went well, didn't go well, and what improvement opportunities do you think we should work on? Sometimes these videos can be very uncomfortable to watch. They also become very powerful enablers of change and quality improvement, enriching both medical and nursing education and changing practice when these improvement opportunities have been identified. Videos as a form of storytelling, we've been able to expand our reach beyond the typical one-on-one feedback interaction. Patient videos are a standing item in kicking off a number of our quality and safety meetings at our hospital, including Quality Committee of the Board, our Medical Quality and Patient Safety Committee, which is attended by our medical and administrative leadership. It's also shown at our weekly operations huddle, which is attended by our senior leadership team, including our CEO and Chief of Staff, as well as shown at unit level and program level huddles. So because of quality and safety initiatives, the opportunity to reflect influences our interactions and how we deliver care. Example that this audience may relate to is a video of a young woman we interviewed last year. In this video, she described her experience where a nurse was attempting to administer medication to her. She believed the medication was supposed to be administered orally, not through IV. The nurse disagreed, and in the video, the patient, in tears, used the words, "Don't yell at me." And hearing these words and the emotions directly from the patient was very impactful, and sharing the video throughout the hospital reinforced the importance of encouraging our patients to speak for their own safety. Take something as big and confusing as a philosophy of patients as partners into something tangible and easy to understand for both patients and staff. We've taken an attempt at conceptualizing our efforts into 2 broad elements. First is partners in care, and simply put, this is how we work with patients and families at the bedside and partner with them for their own care. With patients and families to share information, be involved in decision-making, up about concerns, and actively participate in their care process to the extent they are comfortable with. An example at our hospital is the bedside shift report. Instead of nursing handover taking place at the nursing station, it takes place at the bedside with the patient and family. The care plan, including discussion items like discharge date, medication, and changes in status, are discussed with the patient present. The patient is not only up to date with their own care, but can also contribute to the discussion and planning. If exchange is conducted at bedside, it is a different conversation that invites the patient to be part of the process of sharing information to participate in care decisions. In addition to involving patient and family, the team is able to collect and understand the information needed for providing care through written information, the chart, but also the verbal communication between the patient and nurse by visually observing the patient in the room for signs of risk. This is one of the ways that we've expanded our definition of the care team to include just staff and physicians, but also the patient and family. One of my favorite stories of how working alongside a patient improved her safety and her experience is now what we infamously call the mango story. An older woman with the diagnosis of dementia was a high risk of falls, in part because she was often found attempting to climb. This included this patient in their huddle during one of her more lucid moments. The patient was able to explain that she often imagined herself back at home climbing mango trees with her siblings. And using these insights, the care team was able to develop an unconventional solution to keep her safe. Got her a bowl of mangoes to keep at her bedside, and amazingly, the climbing stopped. The second broad element that describes our efforts in partners in continuous improvement. This is the work we do to include patients in our organizational and system level planning. Designed with patients' input ensures that we meet their needs and the needs of our community. We know what they want, but in order to truly know, we need to listen. And some of these we collaborate with or seek input from patients and families are from our patient experience at partners, which may be called patient advisors elsewhere. These individuals share their own ideas and points of view to ensure the voices of patients and families are heard, considered, and included at various points across the organization. These methods are used by the organization to continuously improve programs, education, and the design of the care environment. Our emergency department is, one of the leaders in our hospital when it comes to partnering with patients. They have experienced partners that's on their ED Quality Improvement Plan working group year-round. One example of a recent co-designed improvement is with our emergency department redesign initiative. And patients were part of a team that co-designed both our ED triage process and layout to enhance patient flow and improve patient experience. This redesign was recognized as a best practice by the Foundation and Knowledge Institute. Out of working together, changes were made with insight that we would not considered otherwise. So we now have a clerk right at the door, greeting and screening patients, taking initial complaint. Wheelchairs are lined up on the side once you enter the ED doors. There's no longer a number system. Patients sit right in front of the nursing station and are called in by a nurse. There are now big numbered overhead signs with footsteps on the ground for wayfinding. While here, like simple and common wayfinding and layout changes, they really speak to an underlying concern they expressed around how we can create an environment that will manage their anxieties and fears. As an improvement team, our patients co-designed what it could be, or what it could and should look like. So with that, just want to start off by saying at MGH we are proud to say we partner with patients and families, working with them instead of doing to or for them. And understand that by listening to the people we serve and partnering with them in policy, process, and project work, we can improve the way we deliver care. Focusing on patient-centered care as a strategic priority, we are continuously improving their safety and thereby the patient experience. Thank you.
Thank you. So now we're going into our Q&A and invite you to type in your questions in the chat box, and I'm going to ask Ioana to please help keep an eye on that for me. We have some questions that were submitted earlier. Are there any questions that you like to forward to Johanna or Mary?
Questions in the chat box. I just want to welcome our participant from Peru. It's our first international participant today. Welcome.
Welcome. Wow, that's great. To the list of questions that were submitted by the participants prior to coming online. I've also got some questions too. Johanna, you've done a lot of work nationally, provincially, and I'm just wondering if you could share with us, what was your biggest learning when you started to become involved in quality improvement around polypharmacy?
I think my biggest learning in the beginning was that I first start to work as a patient advocate, bit of an us and them attitude. They're kind of we're the and the doctors are the bad ones, because you've usually come to the work from somebody in your family experiencing harm. When I got involved with polypharmacy and I started working with some of the physicians and nurses and OTs and PTs, you find out that actually they're often really on the same page with you, seeing the same problems. They have ideas on how to fix things. They are unable to get the system to change themselves, and they're embedded in the system. So they have to be careful about what they say and who they say it to. I actually had an experience where in a breakout section, I was the only patient at a table of professionals discussing what was going on, and we really felt that things were going in direction. So when we were going to do our report out, everybody looked at me and said, "You have them." What you find is the patient can say things that the health professionals also believe, but can't say because of their position, or they fear being marginalized. We're already marginalized, so we don't mind giving the bad news and being the really friendly critic. That's my answer.
Thank you, Donna.
Question in the chat box. It comes from Diane and it's for Marie. How do you protect your staff from feeling shamed by the videos? It might be difficult to hide the identity of the staff member being part of the video.
Absolutely, and I recognize that concern. And so and I think it goes back to one of the earlier comments that I made, is that you do have to have the right culture that supports this environment and this type of open and candid dialogue. We work very hard here around a just culture, and I will say that the evolution of videos has taken. It's definitely advanced since the early days. So again, the maturity, the type of conversations that we can have now would have been different than the types of conversations that we had 5 years ago when we first introduced them. I think what it's done is through 150 patient videos, you can appreciate that when we have the conversation around the patient and not about shaming or blaming, it really kind of frees us to talk about our own reflections of what we heard in the video and what it would compel for us. So we recognize that this type of format does not work for any type of organization, but it works here.
Thank you. I have a question, Mary, for you. How come to know when it was the right time for change or the right time for that particular format?
So, it goes back to also one of the earlier slides, just around the context of we are a nation that believes in lean or continuous improvement. So we have a just kind of philosophy here as well. And what I mean by that is that we're willing to take the risks of, assessing a risk, understanding what the value could be, and then believing in tests of change. So we understand that we're open to trying an idea. If it works, let's go with this. If it doesn't, let's learn from it, and then move on. So it's really culture and a philosophy. Makes sense. And when a patient says this is important, we listen. And the beauty of some of those channels that we talked about, we have a number of channels in which we collect patient voice. We can start to understand, what is a patient voice of one, and what are some of the larger patterns that we're starting to identify, and that can also help inform where our priorities are.
Mary, any questions in the chat box?
If you allow me, I do have a question. I have it for both Joanna and Marie. They both are kind of leading the way in patient engagement. They've been doing this for so long and so well. It's truly an inspiration. What worries you about what comes next? Maybe I will begin with you.
I'll tell you what worries me in my very darkest moments. Is that the healthcare system very slowly. And I guess one of the fears I have is that, we have very well-developed patient engagement. An organization here in BC called Patient Voices Network. It's supported at arm's length by the Ministry of Health through the BC Patient Safety and Quality Council. We have, several hundred volunteers, have liaison people that work with all the health authorities to let them know that we're available and to solicit our engagement. So I see a lot of activity. I don't see things change very fast. So in darkest moments, I think, are we enabling the healthcare system to stay the same that they're engaging patients. I know that is a dark thought, and it's not necessarily a true one, because in fact, issues of over-medication, I've seen so much change in that area. Anyway, those are dark moments.
Thanks, Johanna.
So for us at the hospital, in a nutshell, I would say organizational fatigue would be risk that we're going to run. So I think in our effort to do the right things and kind of take on these ideas and initiatives in a balance between voice of one and collective voice of a larger pattern that we've identified, we run the risk of being overwhelmed and kind of helping to support our staff with these change initiatives and continuing to sustain them. That would be for us.
You have some really good questions in the chat.
Yeah.
I'm starting to be aware of the time. So I would like to ask Marie and Johanna and the other speakers too to answer some of the questions in the chat, and then we can come back to them in Q&A.
Okay, we're going to move on now to the honorable mention in the patient category. We Adrienne and Alifa from Holland Bloorview Kids Rehabilitation Hospital in Toronto. Adrienne Zarem is a family leader and the mother of 2 young girls, one of which has autism spectrum disorder. Adrienne's work with Holland Bloorview includes sitting on the hospital's Family Advisory Committee, chairing the Family Leader Accreditation Group in preparation for the hospital's 2017 accreditation cycle, assisting in the panel national initiative to implement pediatric rehabilitation reporting system. Alifa Kahn is the mother of a boy with special needs and current vice chair of the Family Advisory Committee. She's actively engaged in the Family Leader Accreditation Group, Ambulatory Care Team, Health Strategy, and Privacy, Quality, and Risk Management Committee. Congratulations, Adrienne and Alifa. Welcome.
Thank you so much. Good afternoon, everyone. And firstly, I really want to take a moment to thank CPSI and Healthcare Canada for this award. It's really a great honor to be recognized for the work that Alifa and I are so passionate about, and we are thrilled to be panelists among such esteemed professionals. Alifa had the great fortune of working with a hospital that honestly really gets it when it comes to client and family-centered care. When Kids Rehabilitation Hospital says that clients and family are at the center of all they do, it's not just lip service or something they're striving towards. It's really something they're committed to each and every day. Their program is a formal structure that ensures the tight integration of patient and family voices in all aspects of the hospital's decision-making and facilitate a shared sense of leadership and accountability. Rewarding roles that I have taken on at Holland Bloorview as a family leader has been my role as chair of the Family Leadership Accreditation Group, or we refer to as FLAG. Against the backdrop of past and pending legislation that is shifting how healthcare is being delivered, Accreditation Canada recently embedded specific and targeted client and family-centered care content into their standards. We sought not only to meet the new standards, but to exceed them, and it enlisted 50 family leaders to form the Family Leadership Accreditation Group, or FLAG. Leaders are now bringing their authentic, lived experience and knowledge to drive quality improvements at the hospital as we prepare for our accreditation in 2017. The FLAG program is highly innovative since leaders are identified, oriented, coached, and supported as equal partners within each accreditation team over the 18-month journey to hospital accreditation. To ensure family presence while capturing collective knowledge and experience in the effort to advance high-quality, safe patient care. In my role as FLAG chair, I've done my best to assist both clinicians and family leaders in bridging difficult conversations by helping to arrive at collaborative solutions and advance conversations about quality and safety processes. Significant improvements have resulted from this work, and we continue to not only build on these improvements, but strive to help change the conversation between patients and clinicians when it comes to patient safety. The FLAG members' presence, collective knowledge, and experiences have resulted in ensuring the right questions are being asked to ensure the advancement of care. Each particular accreditation standard has criterion that the organization must demonstrate the ability to achieve, and each criterion has statements of how the organization partnered or co-created care with clients and family leaders. Other challenge the hospital to demonstrate what have achieved specific criterion, especially when it relates to client and family-centered care, while also participating in creating processes to improve what is already in place. We have flag members to consider a number of questions when reflecting on accreditation standards and criterions, and I'll give you an example of a few of the questions that have been asked of them. Number, think when an experience has gone well when looking at a criterion, and what do you think to that moment in time? Number, think of a time when things were not ideal when looking at the criterion. What could have been done to make the experience more successful? Number, is there a common theme in client experience across other standards or required organizational practices? And finally, 4, is there evidence to support client and family involvement? In asking flag members to reflect on these questions, we quickly realized that their ability to answer these questions was tied to their understanding of the general principles, philosophies, and terminology related to patient safety. This idea that drove the hospital administration to champion the truly innovative idea of our family leaders participating in CPSI's Patient Safety Education Program. Prior to this, the Patient Safety Education, or PSEP program, had only been offered to staff and providers in the healthcare field. The leadership at Bloorview that envisioned the flag itself realized that for our flag members to be true partners with their staff members, it was imperative that they were, quote unquote, on the same page when it came to patient safety. Senior leadership at Bloorview enthusiastically embraced this idea, and last September, the first ever group of family leaders was trained in CPSI's PSEP program. My colleague Alifa was the family leader responsible for advancing and shaping this initiative, so I'll pass the baton to her to highlight this work. Alifa?
Hi, good afternoon, everybody. Can everybody hear me?
Yes, we can hear you.
Hear me? Okay, perfect. Thanks. Good afternoon. I first and foremost really wanted to start out by saying thank you to Healthcare Kahn and CPSI for nominating once again Adrienne and myself for our work. Although I think that at this point in time, Adrienne and I have really found this to be more work, but more about passion. So to further extend what Adrienne has started to talk about, 14 family members and 3 youth leaders, as well as 1 child leader, were trained back in September, early October. What we want to really do for the family portion of the CPSI training to help our family leaders was to really have our family leaders as well as youth leaders, actually our child leaders, be able to engage in an active role in patient safety and created, as well as to learn and improve on our understanding of these things that happen or the things that can occur, because our family leaders as well as children and youth are all consumers within the healthcare system currently, and as such, they're able to improve that process as we go further. We really wanted through our training, we really wanted to enable our family leaders, youth leaders, and our child leaders to the factors and issues that are surrounding safety. We changed the of this from a classic provider and profession-centric type of learning, more of a patient and family-centered, as well as enhanced learning, whereby which we were able to authentically engage, as well as create a partnership where both leader as well as the families and patients throughout the flag process are being able to engage each other to provide positive outcomes. A couple of the things that we really wanted to emphasize during this is we really wanted to create a dialogue in which families as well as providers at Holland Bloorview were able to have in lingo and understanding of what we were looking for, or what we're looking for in terms of enhancements and improvements surrounding safety, as well as other organizational or systemic issues. So the hope is to 3 years about 200 our youth, families, as well as children leaders to be certified through the CPSI program that we kind of honed in a family patient care setting, and to be able to have them understand system 3 safety and culture, teamwork, and how to communicate is being able to effectively partner with your healthcare organization. So much as all of this was done within the scope of flat education, I hope all of this knowledge as well as these and this partnership that's been created can also blossom out of our current environment and also extend towards, system and hopefully creating that dialogue where we're all speaking the same and we're all really working towards having a vision whereby which all of us are, not only taking from, but we're also receiving. So we have the provider as well as the clinician who is the master or experience within their trade, but you also have the family who's also experienced to the family side of the experience in terms of how things are received and how it really is. So you have the lived experience versus the actual academic or professional experience, really being able to come together in a way that's able to benefit, hopefully, the system in a way that empowers the system and makes changes that are beneficial not only to the providers but also the users and consumers within the system. I think that's about it. If anybody has any questions in terms of the actual framework that we use, would be grateful to answer that. The only other thing that I would really like to emphasize is that we did, throughout this program, we coined an actual new module or pilot module that we offered to our families and youth leaders, which is called the Clinicians and Partners, whereas the traditional PSEP module they use the as partners, we kind of turned it on its head in order to really kind of highlight some of the things that happen in the background that patients and families are not necessarily aware of, and those are things that can cause or create barriers when it's not really transparency with respect to the dialogue that's going on in the room, especially when you're being seen as a patient.
Alifa, thank you to the panelists for answering the questions in the chat box. And are there any questions for Adrienne and Alifa? On to Charles Pharand. Unfortunately, Charles cannot be with us today, but he did send his regrets. He received the honorable mention in the patient category and is a volunteer ambassador at Bruyere Continuing Care St. Vincent Hospital Volunteer Resources and was nominated by Heidi Duhame for his role in the volunteer ambassador program. This is a vital role that aims to make sure that patients and family members feel welcomed, are cared for, and are as comfortable as possible. In this role, Charles orients the patient family by reviewing the admission packages, answers questions regarding services within, and introduces them to the people and the unit. He is also involved in training new ambassadors. So we thank Charles for his work. Congratulations. Move on to the Q&A for this group. Are there any questions from the participants?
I'd like everyone to put their questions in chat. Maybe I'll recap for those who cannot see the chat that there were some good questions. One was for Mary, that there is sometimes a concern that by involving patients in the design of healthcare services will cost more money. Any evidence that the experience can be improved without increased cost? And Mary has answered that in the chat box and said that learned is that many of the concerns that patients raise do not necessarily cost money. Often it's just a change in the way we interact. Another question was around if Mary can share her resources, and she encouraged the person asking the question, and probably all of you, if you need any resources, to email her. She provides her email in the slides and also in the chat. Maybe from Danny, how do you help ensure efforts towards patient engagement, patient partnership remain authentic? So maybe we can direct this question to our colleagues at Holland Bloorview. It would be good to hear from them. Joanna has provided an answer in the chat box, but this is an important issue that here at the Canadian Patient Safety Institute we hear over and over again we want to make sure that the engagement with patients is meaningful. How does it meaningful at Bloorview?
Adrienne?
Yeah.
And I think I say that I ensure that things stay meaningful for me, and I help to encourage other family leaders is to be honest about what they're good at and what their skills are and what they bring to the table. Because often hospitals have agendas, and physicians and clinicians and administrators really want to bring in family voices for certain initiatives, and there's often that number of people who are very keen to work on things and will say yes, but sometimes those people aren't the people with the best experience and understanding of knowledge for those specific initiatives. So I think we need to do as patient advocates and family leaders is be very, very honest about what we can bring to the table, defer and look aside to our colleagues and to our friends and to the people that we work with to make sure that the voice that comes to the table is the most well-informed and not just the voice that the hospital typically goes to because they know they can count on it.
Hi, Sal here. Hi, Alifa here. I just wanted to add to what Adrienne said. I think a really important thing as well to encourage and foster that engagement process is to, whether you're family, you really have to acknowledge your own period with respect to your own grieving process, because usually when you are put in that position to really want to be in that way, it's usually an experience. And I would definitely say, and that kind of starts that passion, that fire to really want to create that systemic change. And I think some people will come in wanting to do that, but they're not necessarily cognizant of where they are within their own grieving process for whatever type of experiences that they may have had beforehand. And what's really important is really being able to kind of, shut old and kind of come into a new, but also really be mindful and present in that moment, in that experience, whenever you're speaking, that you're being heard. But what's also very important is to having an organization that's really embed that practice of really wanting to authentically engage you as a family member in order to really work with all of the wealth that you bring to the table, or the gifts that you bring to the table, that can really improve things are done within the organization. I think over at Holland Bloorview, what's been really phenomenal is that you have management as well as clinicians and senior management, clinicians and staff who are all very willing to work with these and the family leaders that they come in contact with, to the extent where it's become the norm, because there's a whole shift where we've all realized, hey, if working together, everybody becomes satisfied in the sense that, there isn't that frustration because we're kind of understanding or coming to that common understanding of where each other is coming from. Mind you, it takes a while before you get there, but that collaborative tension that does develop really makes for an enhancing experience and more of transparent and process as you get further down the road.
For answering that.
More other questions right at the moment in the chat, so I encourage everyone to go to the chat box and answer questions as we move through the next two presentations.
Okay. We're going to move on to honorable mention in the organization category again to Montreal Children's Hospital. They were nominated by Gabrielle Cunningham-Allard for the We Should Talk initiative. The team is represented here by Sasha Dabrowski, a pediatric emergency medicine physician at McGill University Health Center, certified as a Canadian Patient Safety Officer and Black Belt in Lean Six Sigma. Currently co-chairs the hospital's Office of Continuous Quality Improvement and has led many projects across the organization, including the We Talk Safety Campaign. Welcome, Dr. Dabrowski.
Yeah, hi. Thank you so much for having us, and thank you so much, Healthcare Canada and CPSI. Everyone hear me okay?
Clear, thank you.
Awesome. So what I'd like to do is just take you through the initiative that we did. To put in a context, this initiative, a year before we moved into a very new hospital. And so there was a lot of change going on in our organization. And so that was the context of this project. And listening to the presenters earlier, especially from the Michael Gowan Hospital, listening to Mary, it sounds like we're at the beginning of the journey that, and they're kind of like ivory tower that we're trying to achieve, get to. And this is one of the programs that is kind of helping us get there. So it was called the We Should Talk Project. Motto, I guess, that was when something's not right, tell us, we are listening because health is our priority. And I'll take you through what sparked the project itself, and the lessons learned through partnership. If you would have looked on our website a number of years ago, you would have seen that what we do most at our hospital is extraordinary team spirit, patient-centered care, and as our partners. And the three physicians that, as we ended up being called the tiers, or being pegged in our organization as the Three Musketeers, because we were three relatively junior staff physicians at the Montreal Children's Hospital with a passion for patient safety, and who got together across different departments and started advocating for different initiatives. And while the three of us were really proud to be part of this organization and really proud of who we were, we had stories that, experiences where we could have probably done better as an organization, as a team, and we could have partnered better with patients, or we could have listened to our staff, a little bit better, and would have contributed to a safer culture. And the problem that we collectively identified was that not everyone at the Montreal Children's Hospital communicating when a concern arises, and that was compromising safe care. We put together a multidisciplinary team that included multiple family advisors, one key family advisor that really started at the very, very beginning, all the way to the end, Aaron Fima, who I'm highlighting over here if you see my arrow. And he joined our project team at the very, very beginning, and our project team consisted of senior leaders, other family advisors, physicians, communications experts, nurses, and doctors, and we moved forward together. We came up with the following vision, that our goal was to inspire 100% of staff and patients within the organization to effectively communicate with the goal of eliminating preventable harm. And the way we're going to do that is through raising awareness and doing performance. And context, once again, is that we are at the beginning of our safety journey, of our engagement journey, of our lean and continuous quality improvement journey. And so while there's lots of metrics in the organization, very few of those metrics get back down to the frontline teams. And when we're measuring patient experience in some units, information was not necessarily being shared with line providers and teams that could actually act on that. And so this strategy, we were hoping that we would influence the organization to improve. This is our kind of timeline. In October 2015, our CEO at the time, Martin Alfonso, who supported the project starting in 2014, delivered a keynote speech. We started visual ads, which were posters throughout the organization, in staff areas and patient areas. We had lanyards that were given to all the staff that had the core values of effective communication and some key strategies to communicate effectively. We launched a series of what we thought were humorous and engaging videos through social media. So the videos were with staff, one of them was with patients, and the other one was with families. And that was delivering kind of the core values and philosophy of who we at the Montreal Children's are as we move into this new organizational building and structure. We had an engagement microsite. We embedded tools into family packages that they were receiving when they were getting in. We had to action in the patient rooms on their whiteboards where they could indicate their concerns if they had any. And we developed the capacity to feedback data to the frontline teams through online dashboards with patient experience metrics. And all happening in parallel to our quality office building the capacity for frontline staff to engage in quality improvement and partnering with families through, this year what we've launched is a Yellow Belt program and Lean Six Sigma improvement methodology that will deliver to about 20% of the organization, including advisors. And kind of the results over time, the campaign was visible to over 80% of the hospital staff. We reached about 950,000 now. We had some updates through social media. When surveyed staff, a third of staff felt that the campaign, in fact, encouraged them to communicate more effectively. Staff reported that the lanyards actually served as a cue to action. I myself, despite being a champion and a lead of this project, myself in a situation with a resident where he's like, aren't you that lanyard that says we should talk? And it brought me right down into like, oh my God, like here I am trying to lead the way forward, and I found myself in a situation where I was not communicating effectively and was caught by this lanyard. Our patient experience data shows that there's a 10% improvement in some of the metrics related to listening and encouraging questions. And our MIT project, which was the cues to action in the patient rooms, patients, about a third of patients actually reported they were more likely to report concerns now that they know how. We actually are implementing the safety culture from Accreditation Canada yearly instead of every 4 years for accreditation alone. We've not necessarily affected the culture as per that survey tool yet, albeit safety culture will likely take 5 to 10 years to get there. And that's kind of what we're aiming to do, is to create that culture where really my dream is that our hospital transforms itself to one where everyone's wanting and willing to improve and engage at the fine with senior leadership and families and patients to just continuously improve. The next step of our project or initiative is, in fact, to deploy this quality program. Really takes, this awareness work, all the additional work that's been going on in parallel, its improvement capacity at the front line, embedded in the quality program, so that we become a hospital where kids can be kids, parents are partners, and staff are smiling. And it's really where we're going forward. I learned as a physician, learning to partner with families on such a project, and was the value of setting up a learning mindset. When I did this project as a project lead, fairly new and young, and I was willing to learn, and I was very transparent about that at the committee level. And I trained no matter whether our partner happens to be a CEO of a major multinational corporation, and experience, and nonetheless I said, listen, we're coming to the table, let's all be novices and just learn together how to do this right. And made mistakes and we learned from them. Our advisor helped us focus on vision. We spent about 2 to 3 months going through the mission and vision exercise where we really took the time to define and slow down to ensure that when we actually started moving, we were moving in the right direction. Partners allowed us to prevent scope creep. Academic physician, I'd like to publish all of this. I'd like to do research on all of this. I'd like to understand the science behind all of this. And so that in a safety initiative, that actually slows it down and derails it. And our advisors would be awesome at saying, are you sure this is really the main focus of what we should be focusing our primary efforts on? And the family advisors and the partnership allowed me to learn is that at the day one, you need to start thinking about sustainability planning. It's great to have a great idea. It's not sustainable and going to result in long-lasting change. You got to think twice. This is our family advisor, and what this is a quote from him at a conference that we co-presented at a year ago at the Health Innovation Forum. Basically, he felt that at the Montreal Children's we had dedicated and bright people who really want to make a difference. Family advisors were crucial to help improve patient safety and keep healthcare providers focused on what matters most. Like some of the other family advisors that spoke today, were concerned by the bureaucracy and the slow pace of change, but were urged that there was just such dedication and a willingness to just board. This is what healthcare is all about. When something's not right, we need to listen. Our responsibility, and key to start partnering. That's it.
Great. you, Sasha. Okay, I urge you to type in some questions here in the chat box if you've got any questions for Sasha at this time, and then move on to first spinal cord rehabilitation team and group our questions at the end of this. So congratulations to Lyndhurst Spinal Cord Rehabilitation Team from Toronto Rehab University Health Network. They were nominated by Joanne Z for their Patient-Oriented Discharge Summary Initiative. Representing the team is Sandra Mills and Heather Flatt. Sandra is the patient and family educator and has a background in therapeutic recreation with a master's in education and over 20 years of experience in healthcare. She has a passion for adult education, health literacy, and self-management. Heather is an advanced practice leader in spinal cord rehab. She is a physical therapist by background with a Master's of Science in Rehabilitation and 18 years of experience in the field of spinal cord rehabilitation. She is dedicated to the implementation of collaborative interprofessional best practices in spinal cord rehab. Well, ladies, again, congratulations.
So thank you so much for the opportunity to present on our work today, and to CPSI for their recognition as honorable mention in the organization category. We also want to extend our congratulations to all of the winners gathered here today. Next slide. Okay. So POD's patient-oriented discharge strategy is an innovative discharge summary designed with and for caregivers with relevant information needed at discharge. This program was funded by the Toronto Central Local Health Integration Network, administered through Open Lab, which is an innovation hub at Toronto General Hospital. We're fortunate enough to be one of 8 pilot hospitals in the early adopter initiative through Open Lab. We had a lot of work to do between January 2nd, 2015 and March 31, 2015. We started with building a project team that included a project coordinator and 2 patient advisors. Our advisors helped drive all parts of the development and design of PODs. They also acted as a facilitator in the PODs meetings. We did extensive patient and staff focus groups and interviews to increase buy-in to PODs and to hear their concerns with the process. These gathered in the pre-pilot survey helped to shape the PODs template for SCI rehab specifically. We engaged in a lot of staff education to increase awareness of what their role is in a PODs meeting. We went to implementation and second evaluation. Heather will talk a little bit about evaluation shortly. For an SCI rehab patient-oriented discharge strategy is to consolidate patients' learning that happens across the rehab journey. To identify outstanding patient needs and questions before discharge and try to have those things addressed in advance of the person leaving this rehab. PODs strives to enhance self-efficacy, confidence, and patient safety, reduce anxiety prior to discharge. Ultimately, it is a summary of the patient's words that summarizes what they need to do prior to discharge and when they go home. The aim speaks to increasing the likelihood of facilitating a safe discharge for patients and caregivers. What is an SCI rehab patient-oriented discharge summary? It's really consistent of 2 main elements. The first is a document that is generated through a teach-back style meeting, uses self-management best practices led by a neutral clinician facilitator. The new facilitator has knowledge of SCI care, diagnoses, and outcomes. The document itself is written in the patient's words and covers 5 main areas: medications, signs and symptoms, and what to do, appointments, individualized contact list. Items are modified from the original PODs template to reflect the needs and issues related to people with spinal cord injuries. PODS template looks like. Going from the left side over, we start with the medications and address any questions or concerns that a patient has about their medications. Try to understand a person's confidence in their ability to take the prescribed medications when they go home. The care plan section is a review of the domains of spinal cord injury and asks for each domain, is this a challenge for you, and what is your plan for managing this at home? And speaks to self-management. If area or domain is not an issue for the patient, we eliminate it from the final handout that the patient gets. In the signs and symptoms and what to do if section, we cover worst case scenarios and engage in active problem solving so that the person has their own identified plan for areas such as urinary tract infections, autonomic dyslexia, falls, and pressure ulcers. List of outpatient referrals, whether that's here at Lyndhurst in our outpatient program or in the community. We also list the appointments that they have post-Lyndhurst, and then we develop an individualized contact list. What we have found is that even though a patient, when they leave, has a list of all of their therapists' contact information, we haven't identified any sort of spike in calls from outpatients to the inpatient team, which is great. This was one of the biggest concerns that staff had, is that when they provided their phone number to patients, when they got home, they were going to get this influx of phone calls, and that has not happened. Notes and section question, we identify any follow-up items that were identified for the last week of rehab, any questions or concerns that the patient has for their healthcare providers, and any tasks for the first few weeks at home.
So it's there, and I'll just touch on the pilot study results. So prior to implementing PODS, we asked a sample of patients discharged from our spinal cord rehab program in February 6 questions that related to their understanding of their care plan and the transition home. The questions address key aspects of safety, such as medication management, the signs and symptoms to look out for, and their overall confidence in discharge. We then also asked all of the PODS participants those same questions. And I'll highlight a few of the results. As you can see, one area we were particularly pleased with was the improvement in understanding of the purpose and when to take medications. That's something we've consistently seen as a low area in our NRC PICR patient satisfaction surveys and heard patient feedback about. Also looking at that, understanding what signs and symptoms to look out for and what to do, again, you can see there's a big difference from the pre-PODS, the February patients, to those patients who received PODS. So it felt like we were really targeting identified needs, and something we consistently heard from our physicians and clinicians in outpatients. That was something that patients really struggled with, of what to do and who to contact if something goes wrong. One of the other places we've seen a big improvement is in that knowing who to call, having the confidence of knowing who to call if you have questions. But as Sandra indicated, it's not that we've seen a tremendous spike in the number of calls. It's just patients have that reassurance that they know who to call for what. Moving on. We also asked the PODS pilot participants more detail about the actual document and understanding, getting their feedback on the meeting itself. So you can see 84% of patients who received PODS felt that the document itself was useful once they went home. 80% of patients identified having a patient advisor, so having someone with that lived experience participating in the meeting was very beneficial. Totally, we heard from those participants that when there was a closer match in terms of level of function or diagnosis, so for example, both of our patient advisors had a high-level spinal cord injury, so they both had complete quadriplegia. So patients who received PODS who had a similar diagnosis found that more helpful than individuals who were ambulatory and might not have had the same needs and questions in transitioning home. So the current state. So based on very positive feedback we received from patients and staff and our management team, as well as the results from pilot, as of May of 2015, 2015, we proceeded with full implementation of PODS. So it is now a standard of care within our spinal cord rehab program. We have 7 trained neutral facilitators. So that includes myself and Sandra, but also 5 clinicians who've actually volunteered to do this over and above their current roles and with the support of their managers. So something I think a lot of the staff have found, it's a benefit to them in participating in PODS as a facilitator. We have 2 additional facilitators who are also being trained. We have 2 staff members who support the scheduling of PODS, which certainly has its logistical challenges. I wanted to highlight, in moving this to the new standard of care, this has been resource neutral. We did not add any new resources or have any new dollars for that. So I think in looking at the impact it's had for no additional resources has been significant. But probably the most, I think, important thing is the feedback we've received from both patients and staff. Some of the comments and the quotations we've heard from patients is that, I feel like I'm ready to go home now. I feel like I passed the test. I feel much more confident. So really getting at that self-efficacy piece. From a staff perspective, I think we've really seen that the staff are sometimes very pleasantly surprised at how much patients are able to articulate what we will do at home. But it's also been a really beneficial reflective practice tool for the staff who are attending a PODS meeting. Sometimes they're seeing how effective or ineffective their teaching has been and then can reflect on what to do different about that. Completion. So as of May, it's been the new standard of care, and we're really pleased with our completion rate. So in the first year, we had a completion rate of 97%, and over this last year, we've had a completion rate of 99%. You'll see that it says PODS eligible patients. There are a small subset of patients that we've identified may not be appropriate for PODS or may not be able to receive PODS. That being individuals who get sent to acute care and don't return, or if someone has left against medical advice quickly. And then the last group, the small group of patients we have who have significant cognitive impairments. In those situations, what we do is we see if there's a caregiver who will be the one responsible for their care, and then it would be the caregiver participating PODS. If not, we're providing a contact list, but the expectation in that case is that person would not be able to self-manage in the community, is often going to a long-term care or complex continuing care environment. So our take-home messages. So we really feel that looking at spinal cord rehab PODS, we've added something that really enhances the safe transition between rehabilitation and home. We know this is a critical time, a period of a lot of stress and anxiety for patients and their families. And the addition of the patient-oriented discharge strategy has really consolidated learning through using teach-back and establishing a very individualized plan for community transition, something that's patient-centered, it's in our words, with a real focus on patient safety, self-management, and building confidence. I'm going to acknowledge all of the PODS team, which has been tremendous in really making this a success. First of all, our executive sponsors, Joanne Z., who's our Senior Clinical Director, and our Medical Director, Mark Bailey, and then all of the spinal cord rehab PODS team listed here, including our 2 patient advisors, Josh Forbes and Anthony Seamus. And it's just been such a dedicated group, and we just also wanted to highlight the Open Lab link, which is where the original PODS is housed.
Thank you, Sandra and Heather. Fabulous work, fabulous work. Thank you. We do have a comment in the chat box. Go down here. So the comment is, I love it that you put the information in the patient's own words in PODS, so institutional academic language gets in the way of the patient understanding important information. Question, does everyone think that the consistent engagement we may end up falling victim to groupthink?
respond to the plain language piece?
Sure.
Thank you very much for that comment, whoever made that, and thank you very much for identifying that that was a strength in PODS. We too feel that is one of the strengths is our ability to write in plain language what the individual's care plan is. And we also recognize that an individual may not be able to identify all the areas they need to address when they go home, but at least have identified some of the things that can get them off on the right foot. This is not a replacement for professional discharge summaries or medical discharge summaries. Those things still happen. This is purely a discharge summary written in patient's words that they can take home.
Okay, thank you for responding. I have a question. I'm interested to know if there were other languages used in this document.
The original PODS patient-oriented discharge summary that Open Lab put together, they actually developed their PODS in a number of different languages and tested it with non-English speakers to start with. We have had a number of patients whose English is not their first language. So we conduct the meeting with an interpreter and go through all of the different domains via the interpreter. The PODS summary is still, unfortunately, written in English. The cost of translation is just too great for us to bear at this point in time.
Okay, thank you. And did you happen to see a decrease in your readmissions when you started to use the PODS?
So something we're hoping to evaluate, we've actually submitted and are waiting to hear any day about doing a formal research evaluation. And one of the questions we would have, right now it's difficult for us to track our readmission rates because patients are being discharged across the province. So we're not necessarily able to accurately capture would be readmitted to because it wouldn't be coming back to us, it would be to an acute care environment. But that's something I think we feel it's likely that patients are going to emergency for the right reason. So what we've always heard anecdotally is sometimes patients are going to emergency department either for the things, so something that could be managed either at home or through a family physician, or waiting too long to go to emergency. So talking through some of those signs and symptoms and what to do, there's probably more appropriate use of emergency.
Okay, we have a question from Montreal. Some I think you answered already, translation in other languages than French, other than French, and what comes next for them?
We'll continue what we're doing right now, ensuring that either an interpreter is face-to-face or over the phone interpreter services so that the patient can engage in their first language. And we will continue to develop the PODS summary in English with the hopes that there is a family member and or caregiver and or community healthcare provider who can use that as a means of forwarding their care at home.
I think we have that complements this is a number of patient education materials that are translated into other languages. So they are getting materials in their own language. It's just the PODS summary itself can't be translated.
Another question, how do you deal with compliance using PODS? Do we have time, Iwana?
I'm of course quite at the end of our meeting, and I know people have to go to other commitments, so maybe we'll take this question via email.
Okay. It looks like I'm going to wrap up things here. Congratulations to all of you, and thank you for sharing all of your hard work and your insight into quality improvement and partnering with patients and families to make our system safer. Most importantly, for resilience and for standing firm in what you believe in to make care safer and improving the overall patient experience. If you know more about the initiatives that these groups have worked on, please go onto the Canadian Patient Safety Institute website, and there are more resources here for you as well.
Thank you. I just want to let the participants know that we have a very short poll and evaluation for this webinar. I would appreciate it if you can take a few seconds to answer at least the first question. The resources we have on the line is to help you move on the next steps. Lee will tell you a little bit about the Champion Awards coming up, but Health Canada has a very good learning program. We have a collection of resources on the Canadian Patient Safety Institute website, so please explore this and let's together, never be alone, and we'll make the care safer. Now I'll invite Sandy Cossey, Senior Director at CPSI, for an announcement. Comment. Looks like muted. Sandy? Oh, I will take over, not being sure what's going on with Sandy's microphone. We are pleased to let you know that the next year's Champion Awards will be in June at the National Health Leadership Conference. We are very excited to partner again with Healthcare Canada on this, and thrilled that we will be able to celebrate those amazing accomplishments at the national scene, where we have over 800 leaders that come together, and they will hear about the Champion Awards. So do spread the word about your success, be proud of it, and invite others to submit nominations for the Champion Awards. More information will be posted publicly very soon. So it's time to close the webinar. On behalf of Healthcare Canada, the Canadian Patient Safety Institute, and Patients for Patient Safety Canada, a big thank you to all of you. I hope you felt inspired. I hope you took home at least one idea that you can implement, one story, one success. A great big thank you to all the winners of this year's Champion Awards. Now you leave me after hearing the presentation that the judges did not have an easy job, right? So good luck, carry on, never worry alone. Let's work together to make care safer.
We wanna thank you.